group and clinical lab in northern Uganda that's been ongoing for the last 10 years. More recently, with some funding, we've really increased the capacity. Today, I'm going to talk about pre-hospital pediatric triage and resource-limited settings. You can see the co-PIs on here with me. Everything is collaborative. The program we built all the way to the co-PI piece to our funding mechanisms to our research. Everything is collaborative and we try to be as participatory as approach with some of the integration of our research. Today, I'm going to start with some background on one of our larger research projects and then talk about a lot of how we are thinking about expanding this to look at some implementation science. And I would love to to get your input and see what questions you have about where we're at and how we're going to move forward. So my background starts with pediatric mortality, and you can see over the last 3 decades, there's been a significant decrease in pediatric mortality. That does not mean it's not still a significant problem. There's still over 2.8 million non-infant pediatric deaths annually. And then, as everyone knows, these are primarily preventable, with the top three being pneumonia, diarrhea, and malaria. The Africa region continues to have limited progress over the last 20 years, are currently, sorry, 20 years behind the world average. And you can see this graph here at the bottom, high-income countries, and the top low-income countries. What I would like to highlight on this graph is two things. One is the implementation of IMCI, so pediatric focused training to regional health centers and hospitals that looked at things like identifying which kids are sick, danger signs, prioritizing early care. But if you look at the slope of the graph, you don't see that a significant decrease until we became synergistic with the MDGs. And those things obviously brought vaccines, education, decreased by millions the amount of individuals in extreme poverty to poverty. And so those things together brought down this pediatric mortality significantly. But as you can see here, after 2010, it's kind of plateaued. And so I always ask that question, like, why do we see this plateau? Um, Part of it is because a lot of these regions are more isolated. There's insurgency, et cetera. In addition to, for example, where we work in northern Uganda, 2 decades of civil war kind of cut off the north from health resources and development. And so it was really tough to build from a health capacity standpoint. And so those communities didn't really receive some of the infrastructure to both social economically and from a health capacity. Is one of the reasons why the mortality is still pretty high in northern Uganda where we work. And here's some of the disparities I have written here. Still a pretty high infant and pediatric mortality rate. When we look at like the more 2 to 5 year old mortality rates, it's still high, and we know about half of these deaths are preventable and occur at the community level, which is sometimes shocking that they're happening in the community, and sometimes that's not documented as well. We know that the rates are higher in these areas, and we also know that it's harder to get to these kids because there's just less health access. One thing we've been working on the last 10 years is building a community health worker training program that's community based and use train the trainer and mobile health. It's called the Laura Quote Project, which is saving lives in Acholi, the local language. And so we've been building some infrastructure there for some time. When I say it takes a village, a lot of people say it takes a village to get work done, but I like to make kind of a joke that it takes a village to get patients where they need to go. This is our ambulance, and you can see it getting stuck in the rainy season in the mud and having the almost entire community or a large group of community members come out and help us push the ambulance to get it where it needs to go. This was 2 weeks ago, this video. I just updated the slides on here with a new video, but these are like constantly being sent from our teams when they're trying to get out to the village to work with the community health workers or to some of the health centers to get where they need to go, or if it's the ambulance. It's just the terrain is really difficult to pass sometimes, especially when there's flooding. And we've had several members of our team get in motor vehicle crashes or get stuck because of the terrain. You can see how challenging that can be. We also know that there are many risk prediction tools and scores that are feasible in the pre-hospital setting, but that have been developed in the in-hospital and health center settings. Three of these were externally validated in Uganda. On the side here, I have some of the clinical parameters, such as vital signs, focused respiratory exam, capillary refill time, and all these had pretty strong discrimination for identified children who are at risk for mortality. Um, and then also more recently, we've seen in a similar setting biomarkers come out that show even better prognostic accuracy for identifying children requiring escalation and care, outperforming danger signs from the WHO. Some of these other risk prediction scores, SIRS criteria, and vital signs, specifically STREM1, which has been kind of repeatedly demonstrated superior, but now in this new cohort with this research group has shown that it's actually performing quite well. And so this is the background to my summary here today. So we know pediatric mortality overall has decreased. However, in some regions, there's been limited reductions. Northern Uganda continues to be one of those regions. We have this large community health worker training program. And then we know that risk prediction scores have strong predictive accuracy in identifying high-risk children in the hospital setting, but not in the pre-hospital setting. Just gonna give myself 1 second here. Okay. So over half of pediatric mortality in low-income countries is pre-hospital, and as I mentioned before, there's no risk assessment score right now for the pre-hospital setting. Our hypothesis is a panel of pre-hospital physical exam findings that CHWs or community health workers can be trained to capture electronically, can identify which children are at high risk. And we want to know what combination of these can help us identify which children will require escalation of care, which we defined as being transferred from a regional hospital in Uganda to, sorry, from a health center in Uganda to a regional hospital, or mortality. And with this project comes several secondary questions, like looking at low-risk patients, which patients are safe to remain in the community and can be identified so that to decrease the burden in the at the health centers themselves. How do we look at training? These are all new clinical parameters that have not been published in the literature for training community health workers. SPO2 has, but things like combining all of these into like an assessment such as identifying jaundice, capillary refill time, focused mental status, all these things in the pre-hospital setting are something that is fairly new. And how do we look at that from a competency perspective? And also, how do we use innovations of mobile health to help facilitate that, especially with the current program that's ongoing, having, the infrastructure and using mobile health for now 10 years for training? How do we integrate that and look at how this will work with the risk prediction score to help us create, a successful model for identifying these children? So several secondary research questions. Some of our preliminary data. So a few years ago, we did a small pilot exploratory study with 4 community health workers, and we wanted to do advanced pro-inflammatory biomarkers at the village setting. So with solar panels, we did CRP at the villages. 4 community health workers were trained to continue their normal training, which was collect vital signs and danger signs, but also add on a CRP point of care test. And we wanted to see if this could predict which children were going to be admitted to a health center in northern Uganda. We didn't have great results. We actually found CRP was not very predictive. A part of this is probably because over half of our cohort had chronic malaria, but there's several other reasons why. And CRP obviously has its own flaws inherently. But we did find a vital sign model showed some superiority and this kind of led to our next step, which was to expand these models with one, a larger sample size, and two, using all the other clinical parameters that are used in those in-hospital sites that have shown success for identifying sick children. And so that's where we're at right now with this project is we're in the middle of an 18-month prospective observational study, looking at all those additional exam findings that are used in the predictive models that are used that have been used successfully. Our sample size is much higher, as you can see. Our outcome is similar, transfer from a health center to a regional hospital, and then also looking at mortality, and we're creating models with malaria, non-malaria, and then looking at all the clinical variables. Here's an example of like a flow algorithm for this study. We actually have 6 health centers now involved in this, but you can see the community health workers around the health center. They collect a ton of data pre-hospital, and then refer to one of these health centers, either a 3 or 4 level health center, which means a 4 will have one provider for the whole health center. 3 will likely have like an advanced, like similar to like an APRN PA kind of running the health center or a nurse. They'll collect that, and then all the data is repeated by the provider at the health center, and then from there, we do follow up after and collect data in between. So it's a lot of data collection and a lot of coordination, as you can imagine, among 6 health centers. And so we're about a third through the study right now, and we're meeting our outcome well. And so I wanted to quickly get more into the implementation science because I'm well aware of what this group does, and excited to be here. The way I've been thinking about this is when we look at like the subway schematic, where we're at right now is we're trying to develop or translate some of the data from the hospital level to the pre-hospital. And we know that these have been successful there. And so part of this is forming that first part of efficacy and understanding what variables would be the most predictive. They don't have to be similar accuracy, but we want to know for training, what would be important for when we think about triage and training community health workers on what to identify. Even if it's not going to be a perfect risk prediction model, we want to know, where kind of the best combination and where, the most accurate variable so we can focus our training as well. And here's the big picture what we're doing. And so you can see on the right here that this larger study that I just presented is a small piece of a much larger program and plan. And so taking a step back right now, the CFAR course, which was recently released by the World Health Organization, which is Community First Aid and Responder, is a course that we've been doing, or a structure that we've been doing similar work in northern Uganda with the community health worker program for about 10 years. And so when that was released recently, we were very excited because we have this train the trainer model, we have the infrastructure, and now we have this new course and we want to disseminate this course, but we also want to add to it. So Uganda, with the African Federation of Emergency Medicine and the Association of Ambulance Professionals, have been working with us. They've created a Uganda first aid course that's similar to the CFAR, with plans to adapt the curriculum with us and create a mobile application that can be used to train community health workers. Simultaneously, as we're developing this, we have this ongoing study looking at triage and risk prediction that I'm hoping will help I guess supplement this training course and also provide a possible tool that can be used for a larger study looking at outcomes and implementation. And so kind of getting into this a little more granular here, we have this course right now and we have this other study going on, but we're interested in looking at how we're going to implement this. And as I mentioned before, we have some structure with the community health worker training. So one of the secondary questions we were looking at was mobile health. And we recently completed a pilot study looking at like a mixed methods, meta inference between, accuracy with these clinical skills and also qualitative data. So we had 3 cohorts. One cohort just got the tablets with the training. Another one got a locked Duolingo type approach where each module they had to finish the whole module monthly before it was relocked. And when they went through each of the modules, it would unlock as you progress. And then a third group had unlocked plus more high fidelity, low frequency simulation added to an unlocked education modules. And we wanted to see, what the difference was. All 3 groups scored well or improved score significantly throughout time, but all agreed that the mobile health supplement was an important adjunct. And this just looked at like how much the modules were accessed based on which group they were in. And this one compares the locked versus unlocked groups. And we found that the locked accessed it much more, most likely because they couldn't move on until they finished that, which we found interesting. Some of the qualitative components to this were they felt like having it locked, they couldn't use it as much as a reference because some of them wanted to use the materials, like jump ahead and see some of the videos as a reference after they saw a patient or something, which is just not really refined as far as like the resources they have on the mobile health to have like additional references. So they were using this as kind of a primary reference on top of some some like materials that they have on hand. Okay, so bringing this all back, let me see, my time is getting close to 20 minutes, so I'm right on time here. So we're finishing this risk prediction model and looking at which clinical parameters are we're going to prioritize and try to develop a tool with that. And then we're developing this curriculum with the WHO, the AFEM, and the ambulance service and our NGOs. Um, and then we're going to work to develop additional content based on that curriculum and the community health worker training program that we have, with a plan to build a mobile application, which our team does right now, but a more rigorous, something that is scalable and that we can look at data over time. It's actually, as a side note, taken us a while to be able to extract data well from our mobile health program, but recently we've been able to improve on how our data collection is through an application that community health workers are able to use offline, which um, is really nice to be able to do. And so our plan is to deploy this training program next fall. Some of the research questions that I think are interesting that we want to look at from an implementation standpoint is specific to the mobile health and training implementation. How are we going to move this to the next step and see what is an effective way to implement training, in addition to having a score, if we use a score for triage, and how we're going to prioritize those patients, um, different types of mobile application interfaces, things like that. And here's some of the progression of funding here. This is me internally in more career development. And then more recently, we got a large grant from Laerdal to build this program. And then we got funding to build a program at Yale called Global Participatory Research and Ethics, which we kind of work at the community level, doing community-based participatory research and developing ethics training specific to community researchers. And that's a multi-site project and also has implementation, which I would like to present at some point if the team's interested. But thank you for letting me present today. It's nice to have an early presentation. I feel like everything's always in the afternoon, so I really appreciate it.
Awesome. Well, join me in thanking Dr. Ebbs for the presentation. And I'll pop in the chat a link to the train the trainer model paper. Awesome. Questions or comments? I know we've definitely got some folks with similar interests and alignment. So I know there were some thoughts going around during the talk. Folks online, feel free to unmute or raise your hand, or in the room, go for it. Not all at once. Cool. For absorbing.
I think I don't really have like a question. I'm a neonatologist working like peds emergency spaces a little bit too. You know, we haven't met yet, I think, but I'm Charlotte. And I guess I'm curious, like what your thoughts are around scaling it broadly. It seems pretty effective, and kind of like the reach of the program. I think was the only thing I was thinking about. I mostly was just very impressed by your work. I'm definitely interested in hearing more about your ethics development stuff. So I hope you get invited back to kind of talk about some of that work too. But yeah, maybe just answer a little bit about future scale.
Yeah, definitely. Thank you so much. So there's about 800 and almost 900 community health workers in northern Uganda, and we have like this infrastructure right now, which is like the perfect initial project. And so we it's really nice because we have everything from the coordinators to like oversight research directors, from everything from physician scientists to community health workers. We have the spectrum with this first 125. And so this is not new to us, like creating an app and disseminating it and evaluating it on a small scale. We've done it like with 30. Initially we had a few community health workers and then 30. The program's been like ongoing using this, but we haven't really studied this in depth. And so I think our plan is to bring it to the 125 community health workers that are in the program, and then kind of study a few things. One is the implementation. Another is kind of the core educational components, and that's a part of the implementation, and then also clinical outcomes, and see and take that kind of initial study and expand it to the much larger group of community health workers in northern Uganda, obviously with several stakeholders from the north, including the universities and the hospitals that we've been working with as well. But that's kind of the initial plan for scaling, and that's why we're putting so much investment into the application and the training model, because if we can kind of find the right recipe, or at least kind of the shell for this, and that with that first 125, I think there's high potential for this being a very impactful program. Laerdal, our funder, has a strong history of improving outcomes, as you're aware, in the NICU realm, and have demonstrated that um, quite extensively. And so they're really focused on clinical outcomes. And as you know, it's the reason no one's done this in the pre-hospital setting is because you need a huge sample size, you need a lot of infrastructure, you need the monitoring, and the sample size has to be incredibly high to see the type of outcomes that you see in hospital. Like if you're looking in the ICU, its mortality is not, something that is like as challenging, or like they're already really sick kids, but it's like we're looking in a population of everything from with half the kids having malaria and undernutrition at baseline. It's really a challenging setting. Um, Sorry, I could probably go off for a while, but I think that's the initial plans for the scaling, is to hopefully get it to more broadly across the north.
Can I ask you, just, we were talking about with, especially with the focus on pre-hospital, we also think a lot about decision making on like families deciding to like opt into transport and go to higher levels of care as opposed to trying to treat locally, or both like the literal cost benefit of the expensive transport, but then the cost of pulling a family member, like probably the mom away from the rest of the family and things like that. Are you guys looking at that at all, or how does that interface with kind of like the core education and process stuff?
Yeah, so I showed a picture of the ambulance, but there's no like formal transport system. That was like the first community ambulance that the team there invested in, and that provides like free transport across the regions that we work. But there otherwise t the transport thing is always a really challenging question, because as you know, and I think that's kind of like one of the overarching purposes of the study is how do we prioritize community to ho regional hospital, because the travel is so difficult to skip around from every child right now gets referred to like a health center, and that center has to transfer to a regional hospital if they're really sick. And like the case that we had of the patient who died, if the community health worker identified everything appropriately, and that kid should have been, in an ideal situation, should have been immediately transferred to a regional hospital. But the steps right now are community health worker helps refer them, provide some basic treatment and refer to a health center, and then it's a half a day to 2 to 3 days before they get to a pediatrician or a physician that can you kind of look at this patient and provide that level of treatment. And so that's kind of one of the significant barriers. I think because of the low resources, and not having a like a reliable transport system, when they are going to transport, it's very reflexive, like if it's paid for. If not, then that's a whole nother situation which we've ran into um, significant challenges with, on just getting like whether it's getting like formula or providing some basic care that they don't have access to because there is a cost at like some of depending on which health center it is. I'm not sure if I answered your question.
No, that's helpful. I think it's a big topic.
Thanks so much. Other questions or comments? Curiosities?
Well, I'm new to implementation science. Like I have mentors, but if anyone's interested in working on this project or any other questions, please email me. There's so many. We have several. I think we have 6 studies going on in northern Uganda right now. But like, as we kind of think about this from the implementation lens, I can see. Obviously, we use community participatory research as part of our approach, but looking at using that as like an underlining theme to this research, looking at implementation is really exciting, and I think we could really use any help, or if anyone is interested, I would love to meet and discuss how we can work together and with the teams there. So thank you again for allowing me to present today.
Excellent. Thanks so much. Again, let's thank Dr. Ebbs. Much appreciated.
If he doesn't think it happens to Liz yet, he should be.
That's what I was thinking.
Yeah, I'm afraid, one of our
She's not here.
other, pediatric EM folks is not with us today, who's based in Utah, so it's even earlier for her. Who would certainly be interested, so we'll make sure she gets the recording.